Welcome to the award-winning AUA Leadership and Business Podcast, an official podcast of the American Urological Association.
Welcome to the AUA Leadership and Business Podcast, where urologic professionals experience the practical application of business acumen essential for success in today's dynamic professional landscape. I'm Dr. Jennifer Miles Thomas, and in today's episode, we will discuss AUA public policy and, in particular, issues related to the urologic workforce. Joining me today for this discussion is Dr. Jonathan Heinlen. Welcome.
Hello, thanks for having me.
Great to have you today. It's definitely policy these days is very, I would say many more people are more active, just the changes that we've seen recently, and especially in healthcare. Can you just give our listeners a little bit about yourself, your history, and your interest in public policy?
Yeah, so right now I'm associate professor at the University of Oklahoma in the Department of Urology. My training's in urologic oncology and robotic surgery, so I do a lot of that. I also do a lot of general urology, teach residents. But for public policy, really started with my involvement with the AACU back about 10 years ago. I was a representative for our AUA section, and at that time I was on the board there. And then ultimately joined the Public Policy Council for the AUA, which I've been a part of for about 3 years now.
That's perfect. Well, you're the perfect person for me to discuss this with you right now. So if we talk about public policy, like as an overview, what are the AUA priorities right now?
So the AUA has 4 stated priorities during this cycle. And to be clear, every public policy cycle starts in the fall and goes through to the following fall, and we start our discussions back up again. So right now we have 4. Number 1 is the ongoing physician payment reform through Medicare and Medicare Advantage plans. Another is prior authorization, trying to decrease the burden of prior authorization on physicians and physician offices. And then the urology workforce in general. And what we mean by that is recruitment and retention of urologists. So we have problems on both ends. We aren't training enough urologists, and we are seeing increasing numbers of urologists leaving practice early. So we want to see that improve. And then finally, just the general idea of improving the urology workforce. And what we mean by that is having access to more advanced practice providers who provide urologic services, and seeing more and better people in offices, MAs, nurses across the board, improving the people working in urology.
So all of those are issues that I think all of us see on a day-to-day basis. I don't actually recall any conversations when I was a resident about public policy. I would honestly say that I also wasn't very aware of the practice of urology. Do you mind just kind of sharing, because we have a big mix of people who listen to this podcast. Can you kind of talk about when we should get involved, or when we should be aware, or other resources where, hey, if I want to actually understand what's going on behind the scenes besides the actual clinical practice of urology, can you kind of just give me a little bit more insight of where can someone look?
Yeah, well, I think there's a lot that goes into that. The first and easy answer is when, and the when is as soon as you realize you want to spend the rest of your life in urology, you need to start being active in the things that are going to influence you. So public policy being a huge one. So we absolutely encourage, in fact, the AUA sections all have financial commitments to send trainees, residents to the AUA Summit every year to become a part of that process. So we're very invested in getting the young urologists involved. Now, the second part speaks to demystifying what public policy is in urology. And I think when you say public policy, it's sort of this monolithic block that's a black box that people don't understand. What it really comes down to is relationships between our organization and the people in it and the people who are making laws and public policy decisions, things that influence our day-to-day work. Um, to a certain extent, we think, that doesn't really, that's not something we can do. I can't do that from my office. But in fact, you can. And I think as we go along, we can highlight some of those ways that we can become more involved.
I agree. And I think it's just challenging as you move through your professional career. Honestly, when you complete your residency or fellowship, you just want to make sure you're practicing great clinical medicine, taking care of your patients. After that, you realize the entire ecosystem that kind of revolves around what you're doing and how you're doing it and how the policies are going to change throughout your career. So I think this is a pivotal time to discuss truly all of our involvement, our understanding, and making sure the next generations really appreciate what's been done and what could be done. So can we talk about just the first thing that I'm always concerned about is the workforce. So what are the current challenges that we have in the urologic workforce?
Well, we have several. We are not training enough residents to meet the growing demand for urologists. Our population continues to grow. And as our population grows, more and more older people need access to all physician services. But urology is like it or not, geriatric specialty to a large degree. People develop more and more urologic problems as they get older. With more older people, we need more physicians in the urologic workforce, but we have not expanded very much the number of residents that we're training over the last 20 years. And that's not necessarily a choice that we're making. It depends a lot on the money that is put into our education system, largely through Medicare.
So we're not arbitrarily able to increase the number of trainees. So the other option is to rework or rethink about opportunities to provide the care. I know you mentioned before, um, we discussed APPs or NPPs, the non-physician providers. How important is it for them also to understand public policy and changes and what the future could look like for their careers?
Right. So I think we have, last time we had the AUA Summit, we had a record number of APPs involved. I couldn't give you the exact number, but it grows every year. Um, Reimbursement of APPs is absolutely critical to growing that part of our workforce. And I think, we need more urologists recognizing that we have a lot of things that we can do as surgeons that others can't, but there are aspects of our practices that we can turn over to people who are not quite as highly trained as we are to trust them to care for individuals who may not need our advanced services.
That makes sense. I think a lot of people are looking at the different models and what opportunities that bring to us. But I hear as the argument for expanding the roles of APPs or NPPs is also the geographic distribution of urologists. I want to say that I heard there was data saying that there were quite a few counties in the US that don't even have a urologist. And it seems like the newest graduates, they may be seeking more urban or suburban areas. And we may have some issues in the future with servicing and seeing those patients who live in rural areas. Is this what you have found also?
Yeah, I would love to see an electoral map, uh, superimposed over a distribution of urologists. And I think you would see that red and, blue counties tend to be ones where urologists are, and red counties where they aren't. And it speaks to population density, it speaks to income levels, um, and urban versus rural practices. So, it's there's a lot that goes into that. Hospitals in rural areas are starting to fall apart. They're not able to attract urologists into rural areas with what had traditionally been fairly high salaries that they could offer to practice in an underserved area. Also, a rural hospital that wants to start up a urologic practice, urology is very capital intensive, one of the most capital intensive specialties that there is. And there's opportunities, but there's also significant challenges for bringing and attracting urologists out of the cities. So, whereas yes, we actually see that many urban areas are well served with urology. In some states, people are having to drive 4 or 5 hours, and that goes for mine. I see people who come to see me routinely from 4 hours away, and it hurts me to say, "Hey, you've got to come back up here and see me." Yeah, there's telemedicine, but I can't do scopes with telemedicine. I can't get a CT with telemedicine, and there's a real need for people, whether they're APPs or board certified urologists, to practice in these rural areas to some degree.
I completely agree. During the Advocacy Summit, one of the things that we do is we actually go to the Hill and talk to our representatives about some the issues that you've mentioned before. And it is surprising, but they're not always aware. And I think really our involvement and our just direct saying, this is affecting your constituents, this is affecting all of us, this is affecting the healthcare of all of your members, your citizens. I think it's very important. So again, our involvement to kind of help share the boots on the ground, what's actually happening versus the pie in the sky. There is 11,000 urologists in the country, but if we are not dispersed evenly throughout the country or based upon populations, we have an entire segment of the population that is really underserved. Well, I think some of the other challenges that we have seen are the different employment models. We know how things have changed over the past few years from predominantly, even when I would say I finished training, there were a good number of pure private practice groups. There have been transitions to employed groups between health systems, academic, private equity. So, how has this affected public policy?
Yeah, it's massive. It's absolutely massive. If you're a physician owner of your practice, you don't have anyone to really call and say, "Hey, this needs to be changed," or "We need to do better in this aspect." You have your public servants who you've elected, and you can talk to them. Um, when you're employed by a hospital, the people who you talk to and you answer to may or may not have the same opinions or motivations as you do. So you may talk about physician reimbursement, but honestly, if you're hospital employed, you're never seeing that reimbursement. You're probably working on RVUs or a salary, and it's a little bit abstracted to you. So you may be getting $55, $60 per RVU, whereas Medicare is paying the hospital, barely half of that. And they're getting your reimbursement based upon the reimbursement they get for the services that they provide on your behalf. So the physicians no longer have that same level of credibility to go up and say, "Hey, we need more reimbursement for our services." Also, I think you see that physicians who are employed in a hospital, they have a different tack on the services hospitals provide. And what I mean by that is if you say, don't like the cystoscope you're using, or what's bigger than that, you don't like the way that the OR does turnover, or you think that they have dangerous practices among their floor nursing. Well, if you're out there in private practice, you vote with your feet. You say, you know what, I'm not going to bring my patients to this hospital. I'm going to go somewhere else. And when you're employed, you generally have a contract that says you're not going to do that. You don't have that option. So how's that have to do with public policy? Well, we tend to now then rely on the hospitals to advocate for us. We have to go to the hospital leadership in order to change our world. Going higher than that doesn't really make a whole lot of sense to the employed physician because their world is sort of controlled by the hospital leadership. So to a certain extent, their lots are thrown in with the hospital, and they would look to the to the hospital's needs and to benefit themselves, if that makes sense.
That makes sense. So, should we be more involved with the hospital leadership also, or should we figure out ways to become more influential or aligned? What are your thoughts?
Yeah, I mean, I think that physicians do not have a ton of agency when they're employed by a hospital. They're kind of on their own. Um, and when you're talking about issues of patient safety, we have different opinions of what that might mean. You know, for hospitals, it's going to be metrics that the government puts out. For us, you know, we may view it differently. So, what options do you have, Hussein? I think we might be skipping ahead a little bit to kind of what I was going to talk about later, but I do think we have options. I do think we have ways where we can advocate for ourselves and our patients without going directly to our hospital, employers and asking them to do better.
Well, what about if we talk about lobbying? I
Hmm.
know that the hospital and the pharma groups definitely have very large lobbies um, that that are really advocating for things that benefit the hospitals and the pharmaceutical industry and also patients, quote unquote, that kind of trickle down. Do you have any idea of some of the numbers that we're talking about here? I mean, are we even on the playing field?
Yeah, this is an area I've become interested in. One of my medical students, Max Bavette, he just put together an awesome article that he based on open secrets, putting together kind of what our financial um, spend looks like on lobbying. So, for perspective, the total lobbying spend by pharma in the United States is somewhere around $380 million. $380 million represents around 7% of all the lobbying dollars spent in the United States, at least those that are openly reported. Hospitals and hospital organizations account for about 120 million. That's 3% of all lobbying dollars. So that's a big slice of the pie. Just between pharma and hospitals, we're looking at about 120 million. Where are health insurance companies in there? It's hard to say because health insurance companies aren't usually broken out within an open secret. So the insurance industry as a whole is also somewhere around 150 to 200 million, right? So now we're getting up to about 15% of the pie are spent by pharma, hospitals, and insurance. Now let's look at physicians. AMA, American Medical Association, representing all physicians, 24 million. All right, that's a big number, but it represents less than 1% of all lobbying dollars spent in the United States. All right, and then finally, urology. In 2024, $368,000. All right, that is 0.008% of all lobbying dollars spent in the United States. So I think if you look at just the numbers and the money being spent, um, the money that we can even provide as an organization is not even close to what the big interests are providing.
Yeah, that seems like a huge imbalance. Uh, a bit, I mean, honestly, a bit disheartening, right? So a lot of our future, we are the ones who put in at least 2 decades of work, sacrifices,
Mhm,
family time, risk in order to deliver this care. Yet
mhm.
a lot of these policies are being dictated by others who may have some similar priorities, but definitely different priorities. Well, how do you think this shift over the past few years from private to employed to maybe private equity to health systems, how has that actually changed our workforce?
Well, financially, it's a big shift, all right? So as an employee, you've got W-2 exposure. Your money, your income is being reported directly to the government. So you are going to pay taxes, and there are not good ways to hide W-2 income from the government. They're going to get it. Um, the other thing is, and what's really hard to discuss with young urologists and residents who see, you know, physician salary is this big dollar figure that they've never earned before, and this vehicle to wealth. Well, it's not the vehicle to wealth that has traditionally been used in medicine. What private practitioners use for long-term wealth is really their office building, which you buy and hold in the long term. Your capital supplies, whether that be a CT machine, a radiation center. These are your vehicles for long-term wealth creation, and you don't get that as an employed physician. As I mentioned earlier, if you own your own practice, you are a leader in your practice. You have to have intrinsic leadership capabilities, and if you don't, then you will develop them or you will go out of business. And when you're in the hospital, you may not have that or need that. You may be just happy to show up, see your patients, and go home. And then finally, also like I mentioned earlier, you cannot vote with your feet if you're employed. And so you have a voice in hospital policy, but at the end of the day, if the hospital doesn't want to do what you think is the right thing to do, they can just say, well, no, we're not going to do that. And you don't have any recourse other than to quit. And that's a little extreme for a lot of us when we have things like non-compete clauses that may have to be fought against if you want to stay in the same place.
Well, you just mentioned quite a few challenges. Are there any potential solutions?
Solutions to the financial problems that come with employment? Well, no, I mean, it would be to go into private practice, own your own building, and employ your own people. But there's a reason, that we're seeing more and more people go to hospital employment, and that's that the private practice model is becoming financially untenable. We haven't seen significant increases in physician reimbursement, which is where private practice gets their money. And we're seeing more and more headwinds against collecting on ancillaries like CT, like radiation, and ownership of surgery centers, which traditionally has been a way to combat the lack of improvement in physician reimbursement. So I don't see a way out of that, and it's been whispered in the halls of the wise that maybe private practice is just kind of going to die on the vine, but I certainly hope not.
Well, I'm going to stay positive. I came from a private practice background, and I think the adaptability, the flexibility, and the need for patients to be treated close to home, consistently, reliably, and to know their physician very well with different incentives is definitely there. So I'm going to stay hopeful.
Well, yeah, let me say something on that.
Mhm.
I would like to say, I probably sound a little bit despondent or hopeless about that, and that's not the case. I don't really. I do feel like there's a value to private practice that goes beyond just the happiness it brings people to have control over their own practice. And I think private practice is what medicine really is about. It's about bringing your values to the public and unfiltered and saying, well, this is what I have to offer you. This is what I believe. And then people coming to see you, not just because you're a good physician, but because your values align with the patient values. And that's something that employed physicians have a little more trouble offering.
Yeah, I think there are multiple different models, and I think part of it is know thyself and know whether or not you have that entrepreneurial spirit or if you have research inclinations. And I think there's a model for everyone, and I think that needs to be maintained. We began our conversation talking about one of the priorities is the workforce, and we need to find a role for everyone because we don't have the option to lose those who don't fit into a standard model that we feel needs to be the only one available. I
Mhm.
think that there's just in my journeys over my career, I feel that potentially not all of the groups are represented as well in policy conversations or going to advocacy summits. And the reality is truly, if you are in private practice, taking off time means lost revenue, which means lost income, right? So it's not really like
Yeah.
you have PTO and things like that. And so I think part of the messaging really needs to be also, hey, if you want to be at the table and not just the meal, you need to attend, you need to understand what's going on. So if we take a couple of step backs and we talk about overall with policy, are there other things that we need to consider, to do, to talk about, just for maybe the next generation, maybe for our APPs or NPPs, for definitive urologists, as we are aging and we are one of the older specialties? What else should we be thinking about?
Yeah. So I think the big picture is what we talked about, urology workforce. Everything is in AUA public policy is about urologists. Okay. When we have discussions with policymakers, I think they recognize, and we need to recognize, we are a small group. Um, we we're not the biggest group of physicians, and physicians aren't the biggest group of our population. So we have to frame the discussion around patients and what patients need. Now, one thing patients need is urologists, right? But that we also need to be supported in some of our other missions. So, prostate cancer is a disease that we own, and we continue to frame the discussion around PSA screening. It's been a big win over the last 5 years that we've seen PSA screening sort of rebound, and that comes through public policy efforts. Um, I would say in the long term, um, we also need to kind of understand that we're not going to probably be able to train enough urologists to cover the needs of all of our patients. So, changing the way we practice, changing the way we train people to practice, and rely more on um, other providers, whether that be the primary care provider or APPs, to provide some of the services that we provide, I think is a real big boon to us going forward.
Yeah, I think there's a lot to consider in these conversations that we're having. But one, I'm pleased that we're actually having these conversations. A lot of times these happened in the doctor's lounge, in the surgical lounge, behind closed doors. Um, but the more and more we're talking about how the world is changing and what we need to be involved and truly what our role is and where we are in the hierarchy, because in our small ecosystems, we are the leader. But if you back up and just like you mentioned with pharma, spending $380 million a year in advocacy and lobbying, and we are at 368,000. It really shows our position and our force. And I think as maybe some of our government officials age over time, our presence will be more and more missed or felt. And I think the more that we can have these conversations at all of these levels, understand the different models, but understand all of us actually have to work together since we are small as an overall group in order to create a change. So I really appreciate this conversation.
Yeah, I mean, you brought up the numbers, and we've been talking about physician workforce. So, we can take that a step further and compare that, right? So, what does $368,000 of lobbying spend mean from the perspective of an individual urologist? Well, that means that on your behalf as an individual urologist, it's about what, $15 per urologist in the United States. Um, I think most of the urologists are carrying that around in their pocket, and if not, hopefully, hope to God, have it in their bank account. Wow, if you could just double that, right? If you could just say, hey, why don't I cut another $15 check to the AUA this year? AUA PAC has several levels of involvement that they can ask for. My level has traditionally been $500 to $1,000, and if we saw that level of involvement from every urologist out there, that's a lot to ask. But we would see our urology workforce producing a similar amount of lobbying spend to the AMA as a whole. Wouldn't that be a message?
Yeah, that would be amazing. I would have to say, I mean, I've been an AUA member, I want to say, since probably 2003 or 2005. but more recently have I really recognized the need to donate. I never really understood where the money went. I never really understood the system. I never understood that it took time, effort, and money. And if I'm only able to do one of the three, then I need to make sure that I'm present for that one that I'm able to offer. I really agree with your call of, hey, there aren't that many of us. I want to say there's about 11,000 maybe in the US, but given our ability to contribute and what we've actually contributed, there is a mismatch. So hopefully moving forward in the future years, more people will either spend their time, their effort, or their money so that we can make some of these changes, because it directly affects all of us.
Yes, I mean, we're seeing more squeeze. If you look at who historically has been lobbying, spending money, um, some of the groups that rely a lot on pharma for their income, oncology, rheumatology, have massive lobbies. I don't think all of that is coming from the physicians, but one of the areas where a lot of it is coming from the physicians is the ASA. The anesthesiologists have worked very hard, and you know, I won't say whether I agree or disagree. They've tried to actually reduce the expansion of their workforce, um, and they've done that through massive lobbying efforts, both at the federal and the state level. Um, and the CRNA lobby has responded and been quite large. But it's that kind of conflict and that kind of existential threat that I don't know that urologists are feeling on the day to day, that they're not reaching into their pocketbook and sending money out to ask for help. Um, I, I do think we're going to see it though. I think we're going to start to see that. I can't say exactly what form it's going to come in, but the fact that we're closing private practice after private practice, that's got to be some sort of red flag.
Yeah, I think the change is here, and I think it didn't creep up slowly, but I think the awareness was not as prompt. But I think people are aware now. I think our involvement, our marketing of the need, and just the day-to-day changes that people see in their practices is emphasizing the need for change. So I really appreciate this conversation, and thank you very much, Dr. Heinlen, for sharing your time and expertise with us today.
Yeah, you bet. I was very happy to be here and talk about it. We didn't talk much about the local efforts.
Mhm.
If you wanted to get into that for a little bit.
Sure. I would love to talk about local efforts and what can be done, what should be done.
Yeah, and so I think what people tend to think of as public policy is federal public policy. People get very into the um, cult of personality that the federal government has, and whether that's the president who, I think for many, many, many years has sort of been a magnet for public policy debate. That's not where a lot of it actually happens. A lot of public policy is really made at the local level. So there's no bigger example than each state's particular involvement in the Medicaid program. Um, my state, Oklahoma, opted out of Medicaid expansion in the initial Affordable Care Act days, and later on, I think people realized that was a huge mistake, and so Oklahoma eventually got on the bandwagon. But that was not through a small effort. It was a large effort by local physician lobbying, saying, "Hey, we need this stuff if you want us to take care of patients." So state and local advocacy is as big, if not a bigger issue for your day to day as federal public policy is. And it takes a
Oh,
different form.
I
Yeah, I mean,
completely agree.
it's just like, these are people that might live down the street from you, right? So if
Hmm.
you live in your state's capital like I do, I mean, these are my patients.
Hmm.
I have state senator, state representatives who come into my clinic, to be seen for lots of different needs, up to and including cancer. And so they have your ear, right? They have your ear. and they come see you in your office. Maybe go see them in their office and say, hey, I have an issue that I want to talk about that maybe applies to what you do. So these are personal conversations, and these are relationships with people in your community that you can have.
I agree. I mean, if you want to start somewhere, you can definitely start locally. I
Mhm.
don't know if everyone always recognizes or understands who their patients are. Yes, they may be their neighbors, but also their patients have a lot of influence at the local level. I know in Chicagoland, the older people are are very influential. So that's something that everyone can start, right? Because we're all seeing patients, so we all can start with recognizing who we're seeing, treating them appropriately as we would for patients, but make sure that we also maintain those relationships. So great thought.
For sure.
Start
Yeah.
locally.
Yeah, the other thing, and we talked about it a little bit beforehand, is that the AUA is a scientific organization. AUA is a research organization. The AUA has taken over a lobbying mission, but the AUA is not a labor organization. And we don't have a labor organization for urologists, and I don't think we will see one at the national level. But employed urologists have the right to organize at a local level. So getting together with your friends at a local level and saying, hey, we have power together is something that I think that local organizations need to start having conversations about, because otherwise we don't have a lot of power individually, and we're either going to stand together or we're going to get picked apart.
I can't say anything else. So that was a great final comment. We will be picked apart unless we stand together. So completely
Yes.
agree. Well, thank you again for sharing your time and expertise with us today.
I thank you so much for having me. It's a great time.
And thank you to our audience for joining us on the AUA Leadership and Business Podcast. Until next time, continue to learn, lead, and excel.
Make AUA Leadership and Business your go-to podcast. Subscribe today by searching Leadership and Business on your favorite podcast app and enhance your leadership and business education needs. Until next time, continue to learn, lead, and excel.